Good afternoon, ladies and gentlemen. I'd like to welcome you to this pediatric session this afternoon. We have two speakers. I'm going to be starting first, and then Louise is going to follow on afterwards. I'd like to introduce you to two major projects that we're both undertaking at the moment, and we are hoping that it will improve our knowledge and it will enhance the pediatric stoma care. I'd like to begin with a 10-minute video of an interview of a child called Nyla. It's quite self-explanatory, so I'm not going to say any more.
There, so it just started. I was in pain. My mum was panicking about it, and it kind of. She just told. We just went to the hospital, and then we had lots and lots of tests from there. It just kept going. I've got the stoma because I have an illness called SIPO, and my nerves in my throat, like when I eat, they don't work very well. So, and when my poo comes out, it can cause me pain if I eat too much solid food. So my stoma just gets rid of most of that pain. I've had it for about a year from February, a year and a few months. Well, the information they gave me is one time I was in hospital.
So Nyla is 11, and she has actually got a condition called chronic pseudo-intestinal obstruction disease. And she's reliant on jejunostomy feeds. She has very little orally, and she had a formation of an ileostomy in February. It used to take me an hour to change her stoma bag because she cried and screamed. I wasn't her initial stoma nurse. Her stoma was formed in a different hospital. So I actually received her after she was discharged and potentially was doing her own stoma care. But I used to go round and persuade her that we could do it without hurting, but it took me several months before she actually became confident and didn't scream and cry through that. So for me, and to see where she is now, it's a major improvement, but just actually trying to encourage her that it would get better. I think it was hard. And following this, until this filming, her mother had never actually spoken to anybody about her thoughts and feelings. So although it was a good purpose to actually record it for today, it actually came out with a very good therapeutic for both of them. So why did we do it? Well, I'd like to introduce you to a study that I've been part of for the last 2 years. And we felt that it's very important managing stress and anxiety among patients. It's been well reported that it's still poorly addressed in practice. And we know that psychological stress related to anxiety has been shown to impact on healing that affects surgical outcomes. So despite numerous reported evidence that there is improved patient outcomes with better pre-operative counselling, consultants still mainly focus on potential surgical complications and forget the patient in a wider picture. So there is little focus on daily consequences and the psychosocial impacts upon the children and their families regarding living with a stoma. There is still minimal literature looking specifically at the social, educational, and emotional issues these children experience following stoma formation. We identified that there is little current evidence available to guide clinicians in the pre-operative counselling to facilitate coping mechanisms in children and their families. Although we identified seven relevant papers, only 2 were really relevant in this purpose. This was an interesting slide, an article that we came across, which was actually published in 1971, but it quite clearly demonstrates that as the medical profession, we're just starting to realise that it wasn't just a surgical technique that improved patients, that they actually had to think about the patient's mind and the patient as a whole. So 2 years ago, we began our study, And we wanted, the aim of the study was to compare staff and patient perceptions of the psychosocial impact on pediatric stoma formation within our centre. We felt and would like to substantiate that a better understanding of the psychosocial issues children face may lead to more realistic pre-operative counselling and support the families, promoting a better coping mechanism for them in the future. So we initially focused on the children from 6 to 16 of age who had undergone stoma formation or a reversal in the previous 2 years. We managed to recruit 9 children in total and 10 parents. We also recruited 16 members of the Pediatric Surgical Medical Team. We used a thematic qualitative analysis, which is one of the most common forms of analysis in qualitative research, and it emphasises on examining and recording themes within data. So families were invited to attend focus groups and interviews. Both the focus groups and interviews were standardised to a single format. We always started with an icebreaker. And this is an icebreaker showing the families together having to make, we gave them the task to have to make an animal using a stoma equipment and some art equipment. And this was the outcome. We also had to choose a winner, but I'm not telling you which one won. We used informal discussion with both the parents and the children, using various methods to gain the information that we were after. Discussions were led by the 2 same clinicians. The data that we collected then underwent thematic analysis to identify key areas that most concern the children and their families. Most of the patients, like Nyla, focused on the negative outcomes than positive ones. The main themes encountered across all patient perceptions focused on issues around leaking, smell, school life, managing the stoma, and information regarding social effects. All patients listed their bag leaking as a major issue, with 8 out of 9 patients placing it in their top 3 worst things about having a stoma. All patients highlighted the noise stomas make, although the younger patients thought it was quite funny. The more older patients felt it was a distraction, and some had commented that it actually affected their concentration in quiet rooms at school during exams. The smell caused by emptying the stoma bag meant that the children did not like using public toilets. This limited time that they had away from home, which reduced the time they had spent on sleepovers or school camps, and so actually reduced the time they spent with their friends. There was a variation in the amount of support provided by each school, and this was also within the areas they lived. The perceived stigma of being different at school and using the disabled toilet was also featured with these children. Or children felt that their school performance and grades had suffered since having a stoma. A recurring theme was reluctant to change their stoma bag at school because they felt it may continue to leak or they wouldn't be able to attach it correctly. The level of active involvement in managing their own stoma was also affected by the emotional responses. Several children described themselves as changing in mood immediately after their stoma had been formed. Parents worried that their children would use having a stoma as an excuse to get out of school work or to do sports, and several of the children actually admitted they did use this as an excuse to get out of school. Parents were also worried that their children would be embarrassed in difficult situations if they had to change their bags on their own. Although bullying was not a theme, as Nyla also highlights amongst the children, they were very conscious of losing friends, and they would make excuses not to go to their friend's house or parties or sleepovers. There was even an older boy who was very positive about having his bag, but he felt that he had lost even some of his close friends. There were major concerns with the parents. The mothers especially worried hugely about poor social development of their children. Although there were a lot of negative issues, these children also highlighted lots of positive comments. They felt, that you can see on the screen, and they felt that taking fewer medications and experiencing less pain was just some of the positives that they could name. So we used a similar discussion with the professional group. Within the group, the discussion, it was felt that patients would generally be well informed about life with a stoma, but this would be dependent on whether it was formed in an elective or an emergency operation. The group felt that training would be independent on age, that most patients would be looking after their stomas independently before they were discharged. This is variable within hospitals and also with some of the teenagers who still rely on parents' care. One member of the professional group recognised that there may be issues using public toilets in schools due to the embarrassment about the smell. Coping at school was expected to be dependent on how understanding the school was. Some members of the team felt that sporting grades would suffer due to poor attendance and reluctance to change their bags in communal changing rooms. There was an uncertainty within the professional team of how well bags actually stuck, and a lot of them weren't aware that they could still undertake contact sports while wearing a stoma bag. There was a variation among the professionals over the social impact of intestinal stomas. Many senior members thought that there would be a risk of losing friends. Others thought that there would not be a difference because this day and age, a lot of social interaction is taken place on online social media. There was a division about whether patients would tell their friends. The majority thought that they would not tell their friends, while some others thought that they would actually like to show off to their friends, and like you would a plaster cast or a scar. Image was felt to be one of the main issues that these children would have, especially as they approached adolescence. The impact of this was thought to be age and gender dependent. So it seems logical, managing patient expectations well would actually lead to improved patient satisfaction and coping mechanisms. But there were major limitations with this small study. First of all, it was quite actually difficult to obtain the information we wanted to with a free-flowing conversation of 6 professionals all at one time in one room. Secondly, we had very low numbers. We had 9 children and 10 parents, although this actually was fairly comparable to some of the other groups and studies that have been done in the past. So in conclusion, on what next? We felt that a better understanding of the psychosocial issues that these children face may lead to more realistic pre-operative counselling and to be able to support the families, which would prompt better coping mechanisms. So we now aim to collect tangible quantitative data from which to guide pre-operative counselling and expectation management of future patients. We've kept the same criteria as our first small study. By using the results of our focus groups, we have now developed 2 questionnaires, one for the parents and one for the child. The questionnaires were reviewed by the surgical team, a specialist paediatric group, an educational psychologist, and 2 lay stoma associations. We had to create our own questionnaire of quality of life issues and psychological issues because there isn't an already quality of life questionnaire out there available that actually answered all of our questions. There are many for adult stoma patients, but very limited, in fact none, for paediatric patients. So we now aim to undertake a national study and with a validated questionnaire. At the moment we have 26 centres chosen or volunteered that said they would like to join in our study. Some of the centres have less than 20 children that will fit into our criteria, while others have 50 plus. The questionnaires are split into themes. The total of questions are 56 for the parents and 42 for the children. The returned questionnaires will be analysed to hopefully give us a large amount of data to use to improve the care for children with stomas. Throughout the study, I needed to keep reminding myself of this quote, because it's taken us 2 years to get this far. We've had to jump over many hurdles, and we've still got a lot more to go. So in the future, I'm not promising to be back next year to present what we found, but hopefully we will have data to share with you. And finally, I would like to thank all of you for being here today, and also for being hopefully involved, and maybe we could do it internationally if it comes off nationally. So I'd like to pass you over to Louise, who's going to tell you about another inspiring project that will run as well. And so hopefully when we have all this information together, we will be able to give these children the support and the parents the support, and also the professionals that support the support that you're after for better future care. Thank you.
Good afternoon, everyone. It's a real pleasure to share this session and to give the lecture. First, I would like to thank Coloplast for their invitation, and it's more than an invitation. I will tell you more later. But just to begin, I would like to say that, in my career, when I've been telling people that I was working as an ET nurse in pediatric, with babies, children, all the people say, "Oh, this is so sad. I don't know how you can, I don't know nothing about it, and I don't know how I would work with them." And actually, it's right, we miss knowledge about the pediatric population, and I think that in the world there are many, many little Nylas waiting for our care. So this is why I'm very happy that Coloplast asked me to be the manager of the writing of a guideline for the pediatric population. And I am working on this project with a great team that I would like to introduce to you. And I will give you an update about the development of our project. So the first time we met, we found a name for our group. So we are the GPS. This one is easy, NAB. So the Global Pediatric Stoma Advisory Board. And yes, you will see that we are coming from many countries. So Esther Sanchez is from Spain, Claire is from UK, Gail Krielman from Canada, Edith Eckerman from the Netherlands, Sophie Verkleyen from France, June Amling is from US, and I'm from Canada. So what we want to do with this guideline is that we want to support better routines and outcomes by providing a central resource for information about pediatric stoma care. When we are looking for articles in the literature or evidence, it is very difficult to find. There's mostly not. And this is a lack, and we need to learn more to give better quality of care to our patients. So the guideline will be about this, and we want to provide also comprehensive information and recommendation, again, for optimal quality of stoma care. And in the guide, there will be many references, and we think that this is very important because I have been experiencing it in my facility. When I wanted to change a procedure, a protocol, it was difficult to support my idea, my point of view, because I had no articles to rely on. But now you will find many, many links in this guideline. So this provides credibility when you want to make some changes. And also our recommendation will be based on evidence, but again, since there's not that much evidence in literature, the group of experts it will be evidence coming from expert, and also the guideline will be revised by stakeholders. So we will make sure that we find as much references as possible. So we officially start on at the end of January. We had a Skype call. Some people, we are 7. Some people I knew, others not. So, but from the first time, there was a good link with all of us. And we met for the first time on March 19. It was the first face-to-face meeting. And we had one day to work. And I can tell you it was so constructive, positive, efficient, and I can assure you that pediatric ET nurses, when you give them a voice, they are so happy, so they will tell everything you need to know. And most of the work has been done online. So what I do is I prepared a first draft, I put it on Google Docs, and I gave each member of the team a color, so when they put their comments, corrections, suggestions, I can know where it's coming from. And I give them a few weeks to do the revision. And now we are at version 4, that is under review until the end of April. And then I will work on version 5. I don't know how many versions there will be, but our goal is to complete it by the end of August. Just to give you some ideas about what the recommendation will be about. First of all, very important, the establishment of a good therapeutic relationship. When you work with adults, you establish a relationship with your adult patient. But when you work with children, you have to establish a relationship with the patient, should it be a baby, a child, a teenager, and then with the family, the siblings sometimes. So it is very interesting. But we will give some tips, okay? Because from birth, when we start with the neonate, with a birth defect, how are the parents reacting? How should we react? What should we do as nurse? What should be our approach? So everything will be well detailed. And we will give information about the major pathologies, indication for a stoma in children. And also we will talk about the type of stoma we see in pediatric. One section will be about the skin characteristic of the premature neonate, the neonate, and the child. And we want to protect their skin, their fragile skin, so we put adhesive product on their skin, but we don't want to deteriorate the integrity of their skin. So depending their age, there are some anatomic and physiologic items to know more about. So this will be this section. Of course, there will be a large section about stoma care. Body profile may be very different from a baby to a teenager. Also, we always question, should we mark ostomy in children? There's no evidence about that. So we have been discussing a lot. We will put global, general recommendation, and when it should be done, and when it's preferable to do it, and when it's impossible to do it. The use of convexity. We are always concerned about should we or should we not use convexity. So again, we will give you recommendation the best as we can. The care of the mucus fistula, do we cover or not? We will have a section about refeeding. And refeeding, even in our group, it was still controversial, and it would vary from one center to another. One nurse said, oh, we did it once, only once and the baby died, so we don't do it anymore. But in some babies, in some neonates, it can be very helpful, but it must be done correctly with the rigorous protocol, and all the members of the team should be aware of it, and they should understand very well the process and who can insert the tube and who cannot, what type of tube, what size. So we will have an extensive section about it. Also the wear time. How long should we leave a pouch in place in babies? Because you know, the premature neonates, they have 2 to 3 cell layers. If you take it off too often, then you disrupt the skin, and it is, you know, they can lose, they have greater water loss. So this will be discussed. Also, we have the rectal discharge management. Although we say that we don't do irrigation in children usually, but sometimes we may have to do rectal irrigation. And also sometimes in a very small baby, you can have 2, 3, 4 ostomies. How do we deal with this? We will talk about the products, the accessories, and we will give also some tips, like when you have to use paste on a child, how do you remove it? Because you don't want to scratch, you don't want to disrupt the skin. So we will have very clever and simple tips to support the removal. So also we will talk about the stomal, peristomal skin complication, how to prevent and manage them. Most of them are the same as the adult, but there are different ways. Sometimes, like the prolapse ostomy. Many babies, they have a prolapse stoma, but we don't manage them the same way as adults. Then, of course, since we work with babies, you know, following birth defect, they have a closure of their ostomy before they are potty trained. So we find them, you know, having 10, 15, 20 bowel movements a day. So they have hyperdermatitis. And how do we recognize that it is irritant, or it is allergic, or it is infected? We will talk also about anal dilation, and this is an important part of the care after stoma closure. It is important to teach the parents how to do it. They must do it correctly, because it can be very detrimental to the anastomosis. And this part, in my experience, it was a very, very difficult part. We had to support the parent because they were more worried about this than taking care of an ostomy. Also, we will talk about stoma rectal irrigation. Then we have 2 major sections, and it is about education and also the impact, psychological impact of an ostomy. And I forgot to tell you that when we were asked to develop this guideline, they told us it should be 20-25 pages, but we are at version 4 already with 50 pages. So we are working on diminishing it, but and education and psychological impact is taking a lot, because you must consider in neonates, in the toddlers, in the teenagers, so it's different, and the way to teach them is different also. So we already found a solution. For those wanting to know more, to learn more, we will put the basis, yes, in the guideline, but we will create links that you will be able to refer to know more later on. We also will address, you know, daily routines in children and teenagers, and also we will talk. We will discuss challenges that are unique to pediatric and how to manage it. So I already told you about the mucus fistula refeeding. We are trying to find evidence-based, and we have done a review of the literature, so what you will get will be what is the most update. You will have also in the guideline comprehensive information and many tips for the pediatric population. And this will be for the stomach care nurse, but also for the nurses working in pediatric. And I think that this guideline will also be very helpful when we are teaching ET nursing or stomach care nursing. Several links, I told you, links to some videos also. One of our members is from Netherlands, and they already have a video. And I saw Claire's video yesterday, and I think it should be put as a link also in the guideline. And the letter is an inspirational letter for kids, you know, maybe to reflect about who should I tell, when should I tell, which word should I use when I tell my friends that I have an ostomy. And also, there will be a list of the pediatric stoma product, but it will be generic. So the future, yes, we are in the present, working very hard, but thinking about the future. So as I told you, we will complete it at the end of August. And we want, as it has been said many times during this meeting, we want to keep it alive, not on a shelf, so we must spread the good news. So we want to take the opportunity to present at regional, national, and international meetings. We want it to be published. And also something very important, we would like to have it translated. I already know other guidelines who are just in English, but maybe in the group we have people coming from many countries, so we already have a good team to translate it. And one of our team members also would like to validate, I think she developed a quality of life of children with an ostomy tool, and she would like us to validate it. And maybe also it would be nice to have a newsletter about a pediatric ET nursing, perhaps an outline. And also maybe we could develop webinars. And we are open to any other recommendation you may have. So we are welcoming your suggestions, your comments, and we thank you very much for your attention, and thank you.